Hello, my name is Katelyn Whitlock, and I'm excited to share our recent case report published in the Cardiopulmonary Physical Therapy Journal. Our paper focuses on the role of physical therapy across the continuum of care for a patient with advanced heart failure who underwent LVAD implantation complicated by right ventricular failure and suspected critical illness polyneuropathy. This patient was a patient of mine both in the ICU and acute care setting, as well as in the outpatient setting. And this perspective, as well as her complicated case, served as an interesting case to share in this format. Orthotopic heart transplant remains the gold standard for patients with end-stage heart failure, but because of limited donor availability, many patients rely on an LVAD or left ventricular assist device, either as a bridge to transplant or as long-term therapy. While LVAD technology has improved, complications such as right ventricular failure and neuromuscular impairments after prolonged ICU stays can significantly limit functional recovery. And for patients waiting transplant, that recovery is crucial to meeting candidacy criteria. Our case describes a 53-year-old woman with viral cardiomyopathy and biventricular heart failure who underwent HeartMate III LVAD implantation. Postoperatively, she required nearly a month of right ventricular assist device support, and she developed profound weakness consistent with critical illness polyneuropathy. At her initial ICU physical therapy evaluation, 3 days after her LVAD implantation, while she was being supported by her RVAD, her AM-PAC mobility score was only an 8 out of 24. She required maximum assistance for all transfers and was currently on high-dose oxygen as well as vasopressors and inotropes. Throughout 34 ICU therapy sessions, as she medically improved, she also made gradual physical progress, reaching 11 out of 24 on the AM-PAC. By the time she discharged from inpatient rehabilitation, over 100 days after LVAD implantation, her score improved to a 17 out of 24, and she was able to ambulate 12 feet. She used a rolling walker to ambulate that 12 feet. However, her subsequent outpatient rehabilitation after discharge home, which was provided in a traditional outpatient orthopedic clinic local to her, was disrupted by limited dosing of therapy interventions. Per the patient's report, she primarily remained in her wheelchair for exercises in the clinic, as well as insurance restrictions and medical setbacks. Over time, this led to functional decline, with her AM-PAC score falling to a 15 out of 24 by the time she presented to a pro bono clinic where she and I re-met over 1 year after she received her LVAD. Within the pro bono clinic, with targeted task-specific interventions and longer sessions, she was able to improve her gait distance to 56 feet. This was just over 11 short sessions. Her personal goals were to be able to meet the functional requirements for heart transplantation, which was ambulation of 250 feet and performing basic functional transfers at a supervision level per her heart transplant center where she was listed, or she was attempting to be listed. As well as she also had personal goals for returning to her home, where she had been living in her daughter's home, as her home with her husband had stairs, which she was currently unable to perform. Unfortunately, these gains came too late, and she was unable to meet the functional thresholds required for heart transplant candidacy before her right ventricular failure worsened. She was readmitted to the hospital and ultimately transitioned to hospice care just over 1.5 years after her LVAD was implanted. This case demonstrates both the potential and the limitations of physical therapy for patients with LVADs complicated by right ventricular failure and critical illness polyneuropathy. Early and intensive rehabilitation clearly improved mobility, but gaps in her outpatient care, including underdose therapy, insurance barriers, and limited clinician experience with LVAD management, contributed to an overall functional decline. We believe this case underscores a need for increased clinician education on LVAD management and better access to specialized therapy services. For patients like ours, timely and well-dosed rehabilitation may not only improve quality of life, but also directly influence eligibility for life-saving heart transplantation. For me, as a cardiovascular and pulmonary clinical specialist, I found it relatively straightforward to provide the safe monitoring needed in the outpatient environment for a patient with an LVAD who I knew had right ventricular heart failure as well. I found it relatively easy to communicate with her physicians that were monitoring her, as well as with her and her family as far as their goals. But I recognize that not every clinician has that education or that capability of doing so from a time perspective. Thank you for watching, and we hope this case contributes to ongoing conversations about how to optimize rehabilitation for patients with LVADs and complex medical needs.